article,
Sorry about that.
I thought the article on kind of managing calcium in the perioperative period was really good. That article should have taught you some stuff, because I actually learned some stuff too as I was reading it. I was like, whoa. So where do you, how do you guys want to do this? Do you want me to kind of let you ask some questions and then we can take it from there? Or do you want me to kind of go through things?
Just go through it. It's probably easier since you are more familiar with this stuff. But I do have some questions about work. I'll talk about it as we get to it.
Yeah, so I broke it down into kind of things in terms of managing the calcium. And so let's start in the preoperative arena. When I see these patients for the thyroid, I look at see what I'm going to get into trouble with. And when I look at calcium, there are a couple of patients that clearly have challenges. The first one is patients who have Graves' disease. And the reason for that is the glands are usually hypervascular. So when we go to try to do that resection, the control of the inferior thyroid artery branches and the superior thyroid artery branches are not always so simple. And the way that you can devascularize, let me close this door.
Yep.
The way you can devascularize your parathyroid glands is by overligating and cutting off the blood supply. And that one comes and bites you pretty badly in the early postoperative period. The other patient is Hashimoto's. And the reason is, again, it's an inflammatory autoimmune condition. The glands are bigger sometimes and they're woody. They're difficult to manipulate, and you can smoke your paraglands that way. So those two are no-brainers. We did one recently who was unbelievably poorly nourished. Bottom line, her gland really didn't handle well and then had bleeding, and then the paras got injured in that way. So those three patients are no-brainers. If we're going to do a neck dissection, especially on both sides, those are the highest risk patients to experience or expect postoperative hypoparathyroidism. And I almost always tell my patients, be ready for that. Outside of those four, the incidence of postoperative hypoparathyroidism should be around 10%. So, you know, across the entire spectrum, maybe it gets up between 10 and 20%, but that's what we're going to be looking at.
So is post-op hypoparathyroidism essentially just an anatomical issue? Either you trash the gland or you guide the vessel?
Yeah. So again, we try not to resect them by either they're intracapsular. Sometimes they go that way. They can also be just stunned by manipulating them, and they're on some fine bed of capillaries that just get bothered. It's usually bad when you're looking at the glands and they're dusky and black. Those all need to be auto-transplanted, which was in the article, and I can go through that if you guys want to go through that.
Yeah. Well, one thing I wanted to ask you is, I know you use the intraoperative nerve monitoring, but that's more for the recurrent laryngeal nerve and the nerves associated with that area. But what about the use of the immunofluorescence? I don't think we use that here, do you?
No, and that's gaining traction. That's another piece of equipment that I'd have to ask for. And right now we're not cash rich, we're cash poor. So that's probably not showing up.
Okay. You do the auto transplant?
I do. We'll do it on the neck dissections that we do on both sides. It's almost impossible to do a proper neck dissection and not devascularize at least one. The one that usually gets smoked is the inferior gland, because the majority of the lymph nodes are down in the anterior mediastinum associated with kind of the thymus. As you go down with the recurrent nerve, you're going to knock out the inferior thyroid artery, which is the dominant blood supply to the paras. So that's got to be looked at very aggressively and then transplanted in sternocleido.
Another thing they notice is yes, they talk about auto implantation in the strap muscles, but sometimes they do it in the arm as well, one of the muscles in the forearm to kind of avoid re-exploration of the neck. So what makes
Yeah.
what makes you
So,
decide arm versus neck?
yeah, so the forearm is a much better place for patients who are being treated for hypercalcemia secondary to parathyroid hyperplasia. So those are your renal dialysis patients and or patients that have hyperplasia from some of the endocrinopathies, which I don't really go after all that much. But the bottom line there, and the reason is you're going to go ahead and resect all of the parathyroid tissue and then auto transplant to the forearm so that if you do have again, hyper response by that transplanted tissue, that you can do a local procedure in the
The
operating
office.
room and chunk out a couple of pieces. We're not doing a whole lot of renal failure patients. It's not one of my passions. I don't even know where they're going.
Gotcha.
So let's talk about what happens once we get the thyroid out. You know, you guys have seen my kind of algorithm and kind of are getting used to what I do. We check almost always a PTH on our totals to see where it lands out. And for the most part, the algorithm was exactly what the article scratched out. If their PTH is less than 16, I'm usually fairly aggressive at repeating in the morning. They're not going to get into hypocalcemic trouble for at least 12 hours to 24 hours as long as your PTH is above 10. And usually we'll already start them on Tums and we'll already start them on recalcitrol pretty aggressively. And those were the doses that I use. I thought in the article talking about replacing which form of calcium was really good. It explained the difference between calcium citrate and calcium carbonate.
Yes.
And as Lindy's probably aware, because she was on that bariatric service, they are your worst nightmare because they
Because
don't.
of the antacids, right? The calcium carbonate needs an acidic environment for it to uptake.
Yep. And they don't have an absorptive pouch. You know, you absorb calcium in your stomach. That's why almost all the bariatric patients are hypocalcemic and they've got to be on aggressive, vitamin replacement therapy and all of that. But it was interesting. We've gotten burned on somebody on PPIs that creates a alkaline stomach environment, and we couldn't get treatment going for their calcium carbonate replacement. And it was fascinating. As soon as I realized that, I made the adjustment. So something for you guys to consider and keep an eye on.
Yeah, I was not aware of that until this article. So that definitely makes a difference since we see so many of these patients.
Do you guys know, this is VJ, do you guys know the difference in availability between calcium gluconate and the oral calcium and why?
The difference, I saw that the calcium carbonate has way more calcium, up to 40%, versus the gluconate only has 20%.
But I think the other pitfall is gluconate needs a first pass through the liver. And so you may not, so if you're treating we use gluconate all the time in when you're worried about hypokalemia and cardiac or hyperkalemia and cardiac issues. But it's interesting. It takes a while for it to kick out as calcium because it has to go through a liver first. So if you really want something emergent, you may have to reach for calcium chloride or something else.
Gotcha.
Good to know. I thought the article did a good job with trying to help you understand the magnesium aspect of it also.
Yep.
That was really interesting too. I don't think we ever associate, hypocalcemia with hypomagnesemia. I was not aware of that.
Yeah, and if you've got a patient who's got some GI kind of enteropathy or some underlying Crohn's or something, and they just can't keep their electrolytes up, and you do a thyroid on them and you drop their PTH, if you don't correct that magnesium, you're never going to be able to get their calcium going again. And then it potentiates all of the effect of that calcium. So all of their hypocalcemic symptoms are all worse. It's absolutely fascinating. The article did a really nice job with that.
Sure did.
So the hungry bone, did you guys check that out? Did you?
Yeah, I saw that. That's when it's like persistent hypocalcemia despite aggressive replenishment, and it's still it can take up to 6 months for it to resolve, correct?
Yeah. So we see the hungry bone kind of symptoms on patients who come in more for their parathyroid adenomas. So the people that are at risk for it are patients that are experiencing hypercalcemia. So their calciums are like 11 or 12, and that they're undergoing a lot of bone resorption because their PTH is driving that. And then you go ahead and whack out their adenoma, their PTH falls, and then the bones are saying, what gives here? And then they start looking for calcium sources. And then the next thing you know, you've got pain. So those patients that are, especially the renal failure patients who have been chronically driven by elevated PTHs, they get the hungry bone the most of all of the patients I've ever seen. And you can actually get away from that by making sure you do a couple of things preoperatively. And you got to be really careful about this. So do it with endocrine. You can actually give them vitamin D preoperatively and load them up. And that response when you drop their PTH is going to be blunted very nicely. But the danger about that is they're already hypercalcemic. And if they're renal failure patients, they've got renal insufficiency. So adding a vitamin D preoperative supplement has to be very carefully strategized. You do not want to push past usually around a vitamin D level of 30. Definitely do not want to go past 35. So you've got to be careful with that one.
Now, is this something you're doing in the office? Because obviously we don't see that as
Right.
inpatient.
Yeah, so we actually do talk to our patients preoperatively.
No, of course.
No, I'm just making fun of you. Aldo. Bottom line is we're pretty careful about making sure we check vitamin D levels on our patients, because if they come in low on the vitamin D on a thyroid resection, that's going to be a struggle. If I do devascularize them, they're going to be more difficult to resuscitate.
Okay.
Got it?
Yeah.
What else in the, so checking their vitamin D, I thought this was really good in the article is even though we have normal calcium levels, even serum calcium levels, you can experience some hypocalcemic symptoms. And so, you check a calcium, it's let's say 8.5 and the patient's saying I'm numb around the lips. There is some variability to this, especially for patients that are used to maybe seeing a calcium that's up around 10.5, 10.6. So we would treat those patients a little bit more aggressively, even though they have a normal serum calcium level. And then it went through all of the calculations on making sure that a serum calcium level is actually the appropriate number to work off of instead of getting an ionized calcium, which is obviously the more functional one for us. They can't run that at our hospital in the time frame that we're interested in from a laboratory standpoint. So you're going to have to actually do the calculation that they gave you in the article. You guys understood that?
Yeah, you have to get the correct calcium with the formula of the albumin.
Yep.
We use a little, we use an app because I don't think any of us really know the formula.
I remember the formula. Hey, the PTH that you get in the OR, that as soon as you take it out, if you're doing a parathyroidectomy, and then how often do you see that that's actually in the bucket right away?
How often do I see what?
The PTH that you draw in the OR is actually really low, like right away. Is that supposed to serve as a baseline?
For our hyperpara patients, we love that. That means I actually achieved victory.
Sorry, I mean the thyroid.
So I never draw it in the OR. I always get the PTH in the PACU, which is about the right time for the half-life to drop off. So what we'll see is, for the most part, a pretty accurate representation in the PACU, which is about an hour later, of what my PTH is going to be moving forward. If it's totally normal, it's very unusual for that to continue to drop for the next morning. That's why I don't always check them the next morning unless I saw something in the operating room that raised an eyebrow, like a dusky gland or something else.
Okay.
All right. What else in that article I thought was good?
One thing that I don't think I have ever seen, but I've read about it, is thyrotoxic storm.
So that's the next article. Yeah, we try to avoid that with all costs. So the first thing for our hyperthyroid patients, that almost 95% of them are on these anti-thyroidal medications, what we call ATMs. And they're generally two, methimazole and PTU. Methimazole is generally the one that's a little bit better. PTU will often be utilized in some of our pregnant patients, if I'm not mistaken, a little bit more often. But the bottom line is, if they're on my ATMs, I'm almost always protected from thyroid storm. We usually will also put them on beta blockers for about a month prior to surgery as the second line of protection. And then we give everybody, as you guys may know, a dose of dexamethasone preoperatively for swelling and neck maintenance and vocal cord management. So those three together is almost always. However, if you guys remember a patient we did recently, they were allergic to both methimazole and PTU, which is really interesting. So we actually did that patient on old school, because I'm so old, potassium iodine. And VJ's probably laughing on the other line. He's laughing. So potassium iodine gets a little notoriety just because we live next to a nuclear power plant. And so these are the pills that they'll start passing out if the Russians are getting a little itchy with their trigger finger. It's not going to protect your thyroid from cancer, but I got news for you. But the bottom line, the concept here is that you suppress the vascularity of the gland through KI, and it's a terrible drug to take orally. You put drops in, usually orange juice with ice to tolerate it. It's bitter, it tastes terrible. Patients complain. They take it 3 times a day, and you do it for a good 10 to 14 days preoperatively. We did it on everybody back in my day because we thought that it would diminish the amount of vascular perfusion of the gland and make it an easier operation. I don't think there really is a whole lot of science to that personally. I don't torture my patients with KI. The only time I use it is if somebody's in the hospital who has to go rapidly to the OR because they're having hypercalcemic crisis that can't be managed easily. We'll start them on KI. We'll also start them on cholestyramine rapidly. It's a very good kind of other adjunct to suppressing that excessive thyroid hormone function, and it absorbs it nicely in the GI tract. And then the other thing we use is steroids for emergent crashes to the OR on hyperthyroid patients. It's pretty good.
You use KI like
You call it Lugol solution, right? And
Yeah, Lugol's.
yeah, I gave the thyroid lecture for the residents a few years ago when I was actually doing thyroids. The only other thing in critical care, thyroid storm can be a great pretender for septic shock. So you talk about all the different shocks out there, and then if you're still scratching your head and someone's really crumping, we've seen thyroid storm as a reason. Very, very. This is like obscurity, but you can see it, and it's very striking.
And then adrenal insufficiency is the other great.
yeah, I know about that one. You also treat it with steroids. Did you use iodine like 4 or 5 years ago on your patients?
Yeah.
All right.
We did it for a while on a couple of them that were just coming to the OR. We did some really crazy big goiters that when we did the ultrasound, it was noted that they had a ton of vascular perfusion to the gland. And again, that was anecdotal, that we thought that it helped, but it really doesn't, so.
Can you talk, I know we've talked, you and I, about it in the past, but can you talk maybe for everybody else about how to get people off the beta blocker and what other meds that should be stopped when you're discharging the thyroid?
Yeah, so for the Graves people that are coming in that are on the beta blocker, I'll usually cut it in half, but I won't make it go away entirely. But there's really no reason to continue them on with their antithyroidal medications. That one's not going to be necessary. So the methimazole doesn't need to continue on. And then how fast you start them on their synthroid replacement, because we whack their whole gland out. I usually don't start it right away. I give them about 72 hours, and then I start them on kind of a knockdown dose of Synthroid at 1.75 micrograms per kilogram. I thought the article was really good about talking about the timing of when you should take your Synthroid and when you should take your calcium, because the calcium.
1 hour before or 3 hours after. Because
Yeah.
I guess the calcium binds to the levothyroxine and it inhibits its function.
Yep. So when we're pounding people with Tums, 3 times a day with meals, they've got to take their Synthroid, in the appropriate window if they've got a total thyroidectomy done. So thought that was pretty good.
Yeah, I found that very interesting. Another thing we want to talk about is something that we could potentially run into is hematomas. I know it personally. I've had to wake you up in the middle of the night to tell you, hey, I know this happens less than 1% of the time. I've never seen one. I'm pretty sure this is one.
Let me ask the team, how do you open the neck if you have a hematoma that's causing airway compromise?
So we've been taught to just go ahead and open it at bedside.
Yeah, but what layers are you cutting? You just cut.
I mean, you open up the skin and then you got to get through the strap muscle.
That's the key, because the hematoma is deep, it's central, and it's below the strap. I think Dr. Colettis nodding and said he probably does interrupted sutures on the strap so that the blood.
Yeah, that's another thing that the article talks about, how hematomas can be deep or superficial to the straps, and usually the deep ones are the ones that cause the respiratory distress stridor.
Absolutely.
And they recommend not approximating the strap muscle tightly so that if you do have a hematoma, it can flow anteriorly and give you a little more time, I guess.
Yep, we
Do you
will.
do that? Because I mean, like, we don't help in these surgeries very often, so.
So
Not sure.
here's the gig. The first layer at the skin is right to left. So you're going to open up that skin, which is a subcuticular, that everybody knows. And then the next layer is going to be the platysma. That's a right to left opening. Then the last one's a vertical north-south on the strap muscles. That's the one that's going to get your sphincter a little bit puckered when you start opening that one up, because you're thinking, wait a minute, I'm near the trachea. Don't be nervous. Just open it up. You can see the suture. Stick your finger in there. You're never going to hurt anybody with your finger. Remember that. And then just open it up. Once you start it, it'll like explode open. And hopefully you'll never see that, but you got to know it.
Yeah, that was a pretty scary moment. I remember that night.
All right, so
Also,
hypothetically,
we had a patient who was on the floor and developed respiratory distress, and the surgeon was in the OR, and she called down and said she's not doing well, anesthesia is here, we can't intubate, and surgeon was not able to go up there, but she opened the neck and knew to go, because we'd been quizzing everyone about this. You need to go down deep and probably save the life.
Yeah. So who gets it? I can tell you the one that's going to be the most dangerous is the big goiter that we resect. And the reason for that is they've got a big space that they can hide their hematoma. They'll get through the PACU. I've got drains in, they go upstairs. And let's say they're a hypertensive patient and that blood pressure is not being well controlled and something starts cutting loose at 8 o'clock at night, right, Aldo?
Yeah, especially when we start coughing.
That's the other one. Somebody who has some underlying cough or gets nauseous from a pain med and starts vomiting and Valsalva vigorously, those are the ones that are going to be at highest risk. So when you go by and see our postoperative patients, Ask them, are you being nauseous or you feel like you're gonna vomit when you get your pain meds? It's a big deal.
So hypothetically, you have a thyroid here, it's 10 o'clock at night. No, Casillas' phone is dead, he's on call, and you're in Madison whining and dining. And this person's having respiratory distress. Do you advise that you intubate this patient before you go opening up the neck, or open up the neck first, or intubate them, and then if their airway is stable, wait till you get here? What's the options here? What's the algorithm?
So the algorithm is always, get anesthesia
Yep.
involved early so that you have a threatened airway so that they know to bring all of their little tricks of the trade just in case it all goes south. If they can obviously get a tube in and secure that airway, that's great. But if they just don't feel comfortable that that's going to look good on inspection, they can even topically take a look before they commit to a push of a medication. Then I would open that neck and have a very low threshold for opening that neck up, right, BJ?
Absolutely. This is the one where they're scared to give paralytics. They consider open, like awake intubation. If you're able to, it's probably best done in the OR if you need that. But unfortunately, your location is going to be either floor or PACU for a lot of these. So
Yeah, I would always do a good fight if you can in the operating room. That's that you got lighting, you've
Yeah.
got a controlled environment. You can open a neck with under local anesthesia with, anesthesia right at the head. By the time you get downstairs, you've got an MD at your side. The only way you're going to be opening a neck up on the floor is that they're obviously an extremist, the SATs are dropping, and you've got to do something to save a life.
So if you get a tube in, you don't have to open up the neck on the floor, as long as they're stabilized.
Correct.
So one more comment, or one more discussion point that I thought was interesting reading in the article, especially since we truly have old school versus new school on the call here, with the topic of drain placements. Didn't get a lot of love in the article.
No.
Yeah, well, let's see, how many infections have I had in 23 years having done the surgery the way I do it? That would be one. So I'm gonna keep using drains. It's how we do it.
Don't fix it.
I give a dose of antibiotics. You want to criticize me for squeezing the orange on that one too? You can do that. Everybody's got their style points. I can tell you that drain saved me a couple of times. Go ahead, BJ.
I've really seen, so the things that came up when I've done this in M&M and whatever is, from personal experience, the drain did not tell me that someone was bleeding. So I over the years just started stopping drain use overall, but I think this is the way you do it, and it's worked, and I don't think you should change necessarily if that's the case. And it's gonna be hard to change. If you stop doing it and you have an issue, then you're like, oh, it was a drain, and it's hard to navigate that inertia sometimes. So, but
Leslie use drains?
Yeah, he does.
I use a lot of drains. I'll stick 2 drains in if I've got something that was wholly horrific. I'll crisscross them right on top of the trachea so that there's no way the drain can kink. And I can tell you right now, it evacuates all of those giant goiters and deep things. And when I went to this course, and the guys that I was following was a guy up at Mass General Hospital named Randolph, and he got up and said, I use drains on everyone. And guess what? I use drains on everyone.
Use a Blake drain.
Yeah.
Yeah, because I think the JP drains are not good. The Blake is
Not as
not
good.
a long fluted drain. It'll probably take a lot of that stuff.
The problem with the drains a lot of the time is you put them in on the side that you want to drain it, and it'll kink on that side. So what I always do is the side that I'm anxious about, I put it on the opposite side, and I use the trachea as a stent, and I drape it over the trachea. I'm an expert drain placer, trust me.
Now, another thing that I saw regarding drains is that it doesn't, like Dr. Darren was saying, it doesn't prevent or diagnose any bleeding. And I mean, most bleeding happens within the first 24 hours, but it can happen up to a week. So why do we remove the drains when they leave on the hospital where we can just keep them in?
Yeah, I don't think the 1 week later bleed is pretty, I mean, if you can get through the first 12 hours, you are you're cold, you're gonna do very well,
Okay.
very well. What else we got?
Seromas.
To leave the party.
Something we don't really
uh,
see because they probably happen, after they leave the hospital. Do you see them
No, we
often in the office?
We see occasional seromas. Somebody will come in with a sore throat. I almost never treat it. We'll get an ultrasound sometimes. I don't go draining them. I usually leave them alone. You can have a little delayed hematoma. Again, because I drain so much, I don't see very many of those. The chyle leak, usually
that's-
only on left-sided neck dissections based on where the thoracic duct empties in,
Yeah.
right, BJ?
I guess I'm still not
Yeah.
clear on how to manage those
Uh,
chyle leaks because they're
That's more for neck dissections, right?
Yeah,
right.
occasionally I'll do some lymph node biopsy over there. I basically tie every single little thing off. If you tie a ton, the odds of seeing a chyle leak are pretty low. Lesnick is the only one that generally sees that getting aggressive on some of those lateral neck dissections over by the subclavian. And the treatment is patients, medium chain triglyceride foods and.
I saw that, but that takes like a month.
Yeah, it's official.
I would consult Dr. Gregory Lesnick if we think there's chyle coming out of my drain.
Will do. Will do.
How about the person that's got intractable hypocalcemia?
Intractable hypocalcemia. In other
Yeah.
words, my PTH is destroyed.
Correct.
Yeah. So the algorithm in the thing to know is if you can get them to be symptom free with recalcitrol or calcitriol and Tums, they're going to do fine. I have never whacked out everybody's parathyroid so that they don't respond. There is a synthetic kind of parathyroid hormone now. It's wicked expensive. So we have not to this day, with all of the surgery we've done, created one of those. We're pretty careful.
I know the article didn't really touch upon it as it was on neural complications, but what about the whole recurrent laryngeal thing?
I know. I had an article actually, because we just had a guy that we did that was really hoarse. Did anybody see him? Yeah, his name was Lausanne, or really nice elderly guy. So he was complicated. We did a hyperpara on him and we had to do a 4-gland exploration. We couldn't find the gland initially on looking on both the right and left side following the algorithm. We ended up taking out his left thyroid lobe because we thought it might have been an intrathyroidal parathyroid adenoma, and I could feel a nodule in his left lobe that I didn't like. And then we decided to explore the intermediastinum. And when we went down to take out the intermediastinal thymus, which is where we found the adenoma, our en bloc specimen had some lymph nodes, and the guy ended up having a papillary carcinoma and a positive lymph node on top of that. So now I'm going to have to go back into a reoperative neck. And when we did that, his right lobe, which we had to go after and get, and I'll explain that in a second, was completely fused to his strap muscle. So I had to resect his strap muscle, and that created dysphagia and some voice change, in addition to the fact that I might have taken out his superior laryngeal nerve on the right side. So he was really hoarse and having trouble swallowing. So he actually was a really fascinating post-operative thyroid. You guys don't see that usually because we're not taking out crazy cancer thyroid reoperations.
So if you have a nerve issue, is it is what it is, and maybe it gets better, maybe it doesn't. There's nothing you can do for it, is there?
No, so there are, if you cut it, there are some ansa cervicalis, which is a branch that's involved going to your strap muscle. We'll see that during our carotid endarterectomies. Those of you that scrub the carotids, the vascular surgeon probably points that out to you guys. You can actually nerve graft that between the two ends if you were uber aggressive, knowing that you cut the recurrent laryngeal nerve at the time of surgery. I can actually show you a video of that reconstruction.
But you have to identify in the index procedure, correct?
Correct. And I can tell you, in the ones that you're going to probably cut, it's not going to be the main trunk, at least not with Greg and I, because we're pretty good at doing the operation. It's going to be a small motor branch that comes off the main trunk that you didn't recognize. That happens occasionally, and they're hoarse post-operatively, and nobody can figure out what it is. Yeah.
One more thing, Dr. Coletti. I saw that they use, or they used to use in the 70s, I don't know if they still currently use that, methylene blue to isolate the parathyroid glands, but it looks like it makes the patient look cyanotic and blue. And is that something that we're still using nowadays?
No, I don't use that at all. I look for the normal fat color of the parathyroid gland. Sometimes they'll look a little salmony. They should be the size of a lentil. And we know where they're supposed to live. So anything that looks fatty, lentil-like, salmony, we just stay the hell away from them and stay tight to the gland.
Gotcha. How about heavy versus total? I think there's a lot of heavies, you do a lot of totals.
I'm a little more aggressive than him. I am a big believer in that you want to do one-stop shopping. I think our injury or our kind of hypopara rate is so low. Certainly our nerve injury is so low that I think you should err on the more aggressive side. The other thing is that if you've got nodules on one side, you probably are going to have nodules on the other side. So I almost always go after those patients. You also are going to get into the patients, if you take one lobe out, that they're going to become hypoparathyroid about 25% of the time, leaving behind a gland that could potentially develop a nodule 5 years later. So you didn't do them any favors there. So I'm a little on the heavy side. I'm older. The newer vogue thing is to try to do less surgery. So even for cancers that you know are early stage, 1 centimeter, no nodes positive, there are people even doing hemis on those. I don't do that. I don't do it for several reasons. One, I've been burned a couple of times by taking out a lobe, and then they look aggressively and they see a met in a lymph node, and now the endocrinologist wants to give like radioiodine, and we can't give it because I got a left lobe that's still in there, and now I got to go back. And when you go back, you want to kill yourself. It's horrible surgery.
It's not easy.
Strap muscles are stuck.
I
The
had to do it for
nerves are
follicular.
raw.
Horrible.
Horrible. There is a very slick lateral approach. So if you do kind of a Coker incision, you know, in the midline, and you have to go back and get, let's say, the left lobe, you whack the right, you can do a lateral approach and sneak in. But the problem is that your anatomical landmarks are all different, and you'd better be very skilled with finding that nerve from a lateral approach. Greg and I have done it a couple of times. It's not our favorite.
So
So,
talking
I mean,
different approaches. Have you ever, has anyone in the region ever talked about minimal invasive, like through the axilla and these other crazy things, like through the?
I was gonna ask you if you ever contemplated, doing that, because I never knew they existed yet, the transfemoral approach.
Yeah, no.
Yeah, no.
BK, I'm a maximally invasive surgeon. That is where
Got
I
Yeah, I saw this crazy video, someone docking a robot like through the front of the mouth, and they create a subplatysmal
Right.
plane to get to the, in whatever. I mean, I just struggled in claustrophobia yesterday. I can't even imagine this.
I refer everyone to a higher power if they're interested in worrying about their scar. You know, we generally do okay. Plus, you'll see most of the people I take they've got something like crazy cheeseburgers sitting on their windpipe, and that's what we go after here.
So on the flip side, I understand you're maximally invasive, so is Lesnick trying to say spare them lifelong synthroid, things like that, by doing Hemi?
Yeah, I mean, he's doing it for kind of symptomatic nodules. So somebody has a 2 centimeter nodule that's, let's say, does not have any suspicion for malignancy. So there's no atypical cells in it. It's a benign goitrous lesion, and then the left lobe has no dominant nodule in it. He'll go after that a lot of the times with a Hemi. I'll do that with a Hemi every now and then. But for the most part, I almost always go after a total. And if you've got any atypia at all, you're definitely getting a total from me almost 95% of the time. Yep.
Alrighty, that's all I got.
Anything else, guys?
Let's,
You guys are always welcome to come scrub in. I mean, as long as Christy's not there, and she's not there on a lot of them, come on down. We're happy to have you. You can always see the anatomy, and you can always close up every time. It's good.
I think it would be beneficial for, complications, which obviously the biggest complications that I have experienced now is hematomas, just so that we have an idea of what we're looking at, since that's not something we see every day. I
Yep.
think it would be beneficial for all of us to see what the strap muscle versus the platysma is. Obviously the strap muscles are deeper to the platysma, but just so that we're all aware of what the anatomy looks like, so that we ever have to get in there, we know what to look for.
Take a video of you closing so we know how to open it.
Why don't you come and scrub in? Spend a little time in the room. That's
Sure.
It's a journey well worth taking. We'll make it entertaining for you. No one has ever been unentertained in Greg's and my room.
I want to come because now I want to see it.
It's the prep work.
I have like 5 cases coming up that'll be well worth scrubbing into. Trust me, one's gonna look like a heart coming out. It's absolutely massive. I saw her yesterday. There's one that goes into the chest. There's several coming up that are well worth it. All you have to do is text Christy to find out when she's coming or not coming. I don't think she comes on Fridays now.
Okay.
Okay.
Sounds good.
Thanks.
Dr. Coletti, thank you for your time. Appreciate
Good.
this session.
Good.
Thank you so much.
Pleasure.
Good.